Ah, you're here. I didn't see you. Come, Dr. Cedric. Come on. It's such a pleasure to have you here again. And we are enjoying your company and we're having lots of fun.
Okay,
So the microphone is yours.
fantastic. Thank you so much. Well, I'm going to talk today about mechanical adjuncts in severe heart failure. And this is really a survey of what's out there because historically there have been so many devices that have passed through. It can be unclear what's still available, what's still effective, what's approved, and so we're going to go through this a little bit. And in terms of this particular conference, we're starting to utilize these devices in such a global way that we're all going to encounter these devices, whether it's incidental or it's part of our target therapy. So, the driver of this, of course, is the demographics of populations being older and older population uh, being at higher risk for heart failure, whether it's systolic heart failure or diastolic heart failure. Uh, we talk about HFrEF and HFpEF. Heart failure with reduced ejection fraction, what we have commonly thought of as heart failure, and heart failure with preserved ejection fraction, which is a relatively new concept, but a very important concept because it accounts for about 40-45% of the heart failure cases that we do. And it's quite interesting when we have a patient in profound heart failure with an ejection fraction of 65%, and their therapy is going to be a heart transplantation. So it's a very, very important part of what we see. And these patients are out there, they're being treated with transplantation. Heart failure, congestive heart failure is a big problem. It's a big problem everywhere. It is typically the number one diagnosis in in developed countries for patients brought to the hospital. The costs are very, very high. And the cost being very high, at least in the U.S., means that the payers, including government payers and private payers, are willing to spend a lot of money on therapies that you think would be unaffordable, but the cost of treating heart failure unsuccessfully is extremely high. Um, and it dwarfs other diagnoses like cancer in terms of cost. Now, when we talk about heart failure, the progression of heart failure, one of the things that we focus on are those patients that are failing and have failed maximum medical therapy. And those patients historically have gone to hospice or to transplantation, and now increasingly to ventricular assist devices, total artificial hearts, and other mechanical therapies. But patients all along this spectrum, and again, this is a large number of patients, well, they have all the same disease processes and pathologies that other patients without heart failure have. I mean, they have cancer, they have bladder cancer, they have kidney stones, they have polycystic kidney disease, they have colon cancer, they have lung failure, they have all of these things. And these patients that we're treating with devices will then see other specialists to treat these other diagnoses. And we're increasingly seeing this in our hospital and through our hospital system. So we think about transplantation as the treatment for these patients, and that's an ideal treatment currently based upon outcomes. The problem is that transplantation depends upon donor heart and having adequate donors. In spite of us in the U.S. being in the middle, hopefully near the end, but realistically we're in the middle of an epidemic of drug overdose deaths and trauma deaths and other things that generate donors. In spite of this huge surge in donors, heart transplant is markedly limited by donation. It's just not available in the same way. And so consequently, a lot of people could benefit from heart transplant. The CDC estimates that under strict criteria, approximately 100,000 people in the U.S. could benefit from heart transplantation. And we were doing 2,000 in a good year. Last year, we do 3,500. But still, it's just the tip of the iceberg. So those other patients are waiting. They're out there. They're exposed to other therapies. the increase in heart transplantation, the greatest increase in heart transplantation, of course, came after the adjunct of cyclosporin in the 80s and plateaued since the 90s. Now we're making some progress by extending donor criteria, traveling further, protecting donors further, using devices to protect donor hearts. But those are very small incremental increases. And so it's not likely in using our current paradigms that we're going to make big changes in heart transplantation availability like we did in 1980s. So consequently, patients are waiting. They're waiting longer, and while they're waiting, their primary disease process is still progressive, and many patients they have a time-related mortality risk that increases. So those patients we're now treating increasingly with a bridge to transplant therapy. They need a transplant. They're eligible for a transplant. They're ready for a transplant, but the donor is not available. So we have to keep them alive until a donor becomes available. So we have the concept of bridge to transplant. And then there are patients that come to us in cardiogenic shock. They're very, very sick. We don't know them very well. They haven't been evaluated. And we have to have the concept of bridge to decision. We don't know if they're going to be a candidate for heart transplant, but they've come in very late in the process and they're in shock. They're very, very sick, and we have to resuscitate those patients, support them, go through the evaluation, and determine who's a candidate for transplantation or other advanced therapies. So the concept of bridge to decision is there, as well as bridge to recovery for those patients who are not or don't need transplant. And then finally, many patients come to us and we don't know whether advanced therapy is in their future. And so there are these patients that come who may have a bridge to nowhere in terms of advanced therapies, and we can't separate them at the beginning. So what do we do with these patients? Well, patients that come in and they're in mild shock and they're recalcitrant to medical optimization will commonly use the good old intra-aortic balloon pump. Okay, we're all familiar with this from our training, even those who don't participate in this field. And this in selected patients can provide 20 to 30% increase in cardiac output, and it's an important adjunct. It's very, very easy to use. It's relatively low risk in terms of the procedure aspects of it. And the consoles have gotten smaller and smaller, and so patients now can be sustained with balloon for a long period of time and be quite mobile in our ICUs. For those patients who require more support, either more cardiac support or combined cardiac and pulmonary support, we have the concept of ECMO, extracorporeal membrane oxygenation, which uses an external device that circulates the blood outside the body. And that gives us access to the blood to do things like put oxygenators in the circuit and take over pulmonary function as well. And these circuits have gotten quite small. We use them in a mobile way where we go to other hospitals to cannulate patients in cardiogenic shock and bring them to our facility. And these patients can be on these devices for a long period of time, again, in the ICU, walking around, resuscitating physically. In terms of extracorporeal membrane oxygenation, there are a number of different forms of it. Veno-arterial, where we support arterial and pulmonary function. Where ideally very little blood circulates through the heart and the lungs. And then we have veno-venous ECMO, which markedly expanded utilization during COVID, where we're providing pulmonary support primarily by adding oxygen for patients that have a large arterioalveolar gradient and are not oxygenating. And then more recently, we have the concept of right-sided ECMO, where we have a cannula that goes in very much like a swan with drainage holes in the right atrium, drains blood from the right atrium into the device, adds oxygen, gets rid of carbon dioxide, adjusts temperature, and then returns blood back into the pulmonary artery, bypassing the right side of the heart. And then from a mechanical standpoint, we have also a very, very important device. This is the Impella class of devices, and this device is a catheter-based pump that can be placed by a variety of different mechanisms via the arterial system across the aortic valve with the tip, the inflow lying in the ventricle, draining blood from the ventricle, decompressing the ventricle, then pumping blood into the aorta and releasing blood into the aorta. So this device has a number of different iterations, including Impella CP, which is placed percutaneously via needle stick in the Seldinger technique. Has a flow capacity of about 2.5 to 3 liters. It's a partial support device, and when it's pushed to its limits or utilized for a long time, one of the issues with the device, the smaller device, is hemolysis. We have the Impella 5.5, which is a surgically implanted device. We'll typically perform a cut down on the right subclavian artery and put a graft there, and through that graft we'll place this device. It has greater flow capacity, up to 5.5 to 6 liters, and it can totally take over left ventricular function. And we also have a newly Impella RP, which is a right-sided device. Has a number of different iterations. This one was placed via the groin, but increasingly we place one via the right internal jugular vein, and it drains blood from the right ventricle and pumps it across the pulmonic valve into the pulmonary artery. So the Impella platform is very important, very, very robust. We have ventricular assist device systems. These are implanted, surgically implanted devices, much more invasive procedure, but can also provide greater support. These devices started out quite cumbersome, pneumatic devices with big controllers, difficult to mobilize these patients. They basically stayed in the hospital. The devices have gotten smaller, have converted from pneumatic to electrical, and the controllers and the power supplies have gotten smaller, and of course we have an ambulatory component now with these electrical devices, which allows patients to leave the hospital. We utilize these patients as a bridge to transplant concept, and the bridge concept is very, very robust, very, very safe, and very, very effective. Based upon that experience, we have many patients where we implanted these devices as a bridge to transplant, but for reasons that were discovered after implantation, they were not a transplant candidate. So these patients kept the device, and it became a permanent implant. So we had a sort of incidental experience with permanent implants of these devices. And in both these concepts, as a bridge to transplant and a permanent implant, LVAD utilization has exploded. We now do about twice as many LVADs as we do heart transplants. Because these are made in the factory and they're engineering feat, this is very, very scalable. And this is I think, is going to be the future. This is a total artificial heart. This device is different than LVADs in the sense that now it's a heart replacement device. We take the heart out. There is no recovery with total artificial heart because the heart is gone. This device is only approved as a bridge to transplant. We have investigational devices that are being used, starting to go through safety trials with the intention being a permanent implant for total artificial heart. Doesn't exist yet. So indications for mechanical circulatory support: bridge to transplantation, permanent implant, bridge to decision, bridge to recovery, or procedural support. Very, very important for patients that have heart failure but are going to go through a procedure that's going to challenge the functionality of the cardiopulmonary system, and they can be supported doing this. And this is applicable to pretty much any procedure. And we started using this in earnest with patients who referred for heart transplantation and met the cardiac indications for transplantation, but they did not meet our criteria based upon an increased BMI. So those patients we referred to our very robust bariatric center, and they had procedures to help these patients, but they were not able to undergo general anesthetic without support. So we started using, especially Impella device, as procedural support for patients undergoing bariatric surgery with very, very excellent results, such that those patients went through bariatric surgery, lost weight, became candidates for transplant, and about 75% of them have gone through transplant successfully. The other 25 are still waiting for the donor to become available. And this, I think, is one of the context in which you're most likely to see these devices, these mechanical circulatory support devices, where the patients are supported, but have to undergo a procedure, a urologic procedure, or a general surgery procedure, or vascular procedure on support. There's the concept of pulmonary support, which we learned quite a lot about and expanded our utilization during COVID. I think many hospitals now have become quite expert at pulmonary support on the basis of the pandemic. And then finally, shock, where a patient is largely unknown and has shock. And when we think about shock in an emergency room or a hospital setting, we think about resuscitation, cardiopulmonary resuscitation, CPR. Well, increasingly, cardiopulmonary resuscitation is being augmented with mechanical support. And my bold prediction is that in the future, cardiopulmonary resuscitation in hospital or emergency room and perhaps even ambulance settings will involve early application of aggressive mechanical circulatory support. Again, we know nothing about these patients, just as we know nothing about many patients who undergo cardiopulmonary resuscitation. After successful resuscitation, then we learn the patient and understand what options are out there. Now, as far as the indications for mechanical circulatory support and what the adjuncts are, for bridge to transplantation, all of the adjuncts are active, including intra-aortic balloon pump, VA ECMO. Now, these are important since 2018 in the States, because with these two adjuncts, then those patients, it's one of the few ways that a patient can become status 1 to the top of our waiting list for transplant. And increasingly, patients are being treated in this way. I would say for the last couple of years, most of the transplants that I've done have been in patients in-house with the balloon pump in place, an ECMO in place, or with an impeller in place. And so that's becoming much more important for reasons that don't necessarily have to do with the patient's physiology, but have to do with the rules of transplantation in the U.S. So Impella 5.5 we'll typically use because it can support full cardiac output with decreased risk of hemolysis and longevity. We've had patients on Impella 5.5 for up to 8 weeks with successful bridging to transplant. HeartMate 3 left ventricular assist device, more invasive. It's a durable device. It can be used as a bridge to transplant. It can be utilized as a permanent implant, rarely as a bridge to recovery. I would say, in my experience, about 7% of patients have recovered and had the device taken out. And then finally, SynCardia Total Artificial Heart, which is approved only as a bridge to transplant. But those patients who undergo this operation, many of them, about 25 to as high as 40%, will become ineligible for transplant due to complications or new discoveries such as occult cancers or strokes or infections. For permanent implants, the applicable devices are HeartMate 3 left ventricular assist device, SynCardia Total Artificial Heart. But the BioVaCore Total Artificial Heart is investigational now, not approved for anything except for a safety trial. Bridge to decision. We have a number of adjuncts, including intra-aortic balloon pump, commonly used because it's readily available. We all understand it, and cost is low, and it does have some efficacy. Again, increasing cardiac output approximately 30%. VA ECMO, Impella 5.5, HeartMate 3 left ventricular assist device, and SynCardia Total Artificial Heart as a bridge to decision. Bridge to recovery, intra-aortic balloon pump, VA ECMO, Impella 5.5, HeartMate 3 left ventricular assist device, and SynCardia Total Artificial Heart. And for procedural support, the short-term devices, intra-aortic balloon pump, ECMO, either veno-arterial ECMO or veno-venous ECMO, Impella 5.5. Impella CP, very, very important in the cardiology world because the cardiologist can place it in the cath lab, do their protected procedure, commonly used for a multi-vessel stenting or for stenting of the left main or totally occluded vessels. And then finally, Impella RP for patients that have primarily right-sided support needs. And for pulmonary support, our choices are veno-venous ECMO, VA ECMO, and the Protect Dual right ventricular ECMO for patients who primarily have right ventricular failure. And we'll commonly use this in a setting of patients who have pulmonary emboli with hypoxia and right ventricular failure. and shock, increasingly VA ECMO. We're using it very, very aggressively now. And historically, survival to home for an adult placed on VV ECMO has been in the range of about 20 to 25%. With a very, very aggressive approach and with all downstream adjuncts available in our hospital on a yearly basis, our survival to home for for adults on VA ECMO is between 80 and 85%. Market increase since the pandemic. So in conclusion, mechanical circulatory support adjuncts are increasing in utilization. The outcomes are markedly improved since the pandemic. We've learned a lot from that disaster. Procedural support is expanding, and that's the context where most of you will see these devices. And because of that, there needs to be very, very close coordination, especially regarding anticoagulation needs for procedures and surgery and anticoagulation needs of the devices. But thank you very much.
Thank you so